Hello, and a very warm welcome to this, the first of our topic-based education sessions for patients and professionals. I'm Mags, I'm Support and Information Officer for Fifth Sense, the charity for people affected by smell and taste disorders. It's my pleasure to welcome our guest speakers, Miss Isma Iqbal and Trevor Jones. Isma is a consultant rhinologist and ENT surgeon at the Freeman Hospital in Newcastle. Trevor is our expert patient this evening. Thank you both for joining us. This evening, we'll be talking about chronic rhinosinusitis. Isma will explain more about the condition and its causes later, but as Trevor has rightly pointed out, the term chronic rhinosinusitis can be confusing for patients. So we thought it would be helpful to just clarify from the outset what the term actually means. So we'll start with the easy bit, rhinosinusitis. Rhino referring to nose, sinuses to sinuses, and itis meaning inflammation of. And chronic refers not to how severe the symptoms are, as some people may think, but to the length of time the symptoms have persisted for. If the symptoms of a condition have persisted for longer than 3 months, despite treatment, it's referred to by medics as chronic. Therefore, chronic rhinosinusitis means inflammation inside the nose and sinuses that has lasted for longer than 3 months despite treatment. But because chronic rhinosinusitis isn't easy to say, we'll refer to it as CRS throughout the session. So just a little housekeeping before we dive into CRS. This event is being recorded, so please make sure you stay muted throughout. If you have any technical difficulties, please private message Helen or Sarah from the Fifth Sense team in the chat. They will be dropping links in throughout as we go, and they'll be happy to help. So this evening's session will be split into 3 parts. Our expert patient, Trevor, will share his personal story, the impact the condition has had on his quality of life, and how he copes with it in his daily life. Trevor has lived with CRS for 10 years, which I'm sure you'll agree more than qualifies him for the role as expert patient. Our expert speaker, Isma, will explain about the condition, the symptoms and causes. She'll talk about diagnosis, patient management, and current treatment options. She'll also be suggesting some self-help ideas for patients with CRS, and she'll talk about research into the condition and potential future treatments. So please feel free to drop comments into the chat box during the presentations. You may also drop questions for Isma into the chat. I will ask them of Isma on your behalf after her presentation, and please be aware that Isma can't give medical advice. It would be very helpful if you would remember to mark your questions with a Q, just so that we can spot them easily in the chat. Okay. We'll then follow that with the Q&A session, and at the end there'll be some time for you to complete a short survey, just so you can give us some feedback to help us understand what we did well and what we could do better, and this will inform how we manage these events in future. So I'd like to hand over to Trevor. Thank you, Trevor, for talking today. If you could start by just telling us about your history with CRS and what you've gone through over the past 10 years. Thank you.
Yes, I'm 73 years old. I'm a retired chartered building surveyor. I live in Gloucestershire. I can actually remember quite clearly the day that my CRS was triggered. I was facing a very large survey of a car dealership. That was in 2014, just weeks before I retired, actually. I struggled to complete the task. It was a large building. And I succumbed to flu-like symptoms throughout the day, getting worse as the day went on. My symptoms escalated over the next few months and years. I lost all sense of smell within 6 months, and with it, the ability to detect any flavours in the food. I had bilateral surgery to remove nasal polyps, that's from both nostrils. Unfortunately, I did not improve. I then began to produce copious amounts of a sticky fluid in my middle ears. The pressure of that caused great pain until my eardrums eventually ruptured, and then the pain went away. The The surgeon inserted ear grommets to try and relieve the situation, which it did, but it was unfortunately, it was temporary. Under pressure from friends and family, I researched ENT rhinologists in order to get help, and I had absolutely no joy really with the NHS, so I resigned to having to go private. I then underwent different treatments, including advanced computer-guided sinus surgery. Unfortunately, that didn't work either. I experienced regular CRS episodes, I call them episodes, usually triggered by contracting a cold or flu-like symptoms. There are then short periods of respite in between these episodes, and my sense of smell only ever recovers for short periods after I've had oral steroid medication. A typical episode starts as a cold, but it just wouldn't get better. My middle ear fluid causes pressure to build up, which results in pain, and this is followed by night sweats, which I assume is a fever, and then weeks of infected pus-like fluid that weeps from one or both ears. This is often accompanied by periods of varying degrees of deafness. Less commonly, but something that has featured more recently in my case, is asthma, which is controlled by inhaled medication. As I get older, my CRS is something that seems to get worse. In fact, the current episode that I'm suffering from started off in August of last year, so it's been going on for 8 months.
Gosh, that's a lot to deal with, Trevor. Thank you for explaining that. So I wonder if you could now just tell us how you've been managing the impact the condition has on you, the strategies that you've used to manage the condition, and just how it's impacted your daily life.
Okay, well, I'll start off with the consequences of the CRS. I've had it for 10 years, so I felt unwell on and off for most of that period, with short periods of respite. I still hate not being able to enjoy flavour in my food or my drink, and that feeling has not diminished over time. In fact, it's quite the contrary. It's very important to me because I love my food and I'm a keen cook. It's one of my hobbies. So, yeah, definitely miss that. With no sense of smell, the world's incomplete. There are undoubted emotional consequences to anosmia. Then deafness, well, that means there are periods where I shut myself away from social interaction, avoiding crowds because I can't join in conversations. Normally I love music and live theatre, but when I've got my hearing loss, those pleasures are denied me. Then asthma with CRS, I found can be quite scary. On 2 occasions, I've experienced panic attacks, something I've never ever experienced before. Often I wake up in the night unable to breathe. It feels like my nose is full of concrete, and then I have the added problem of gasping, trying to get air into my lungs. I once called 111 and was sent to a local hospital, and they gave me my first Ventolin inhaler. I'd never had one before. And then on another occasion, when I went to my GP on an emergency appointment, I was immediately put on a nebulizer because my blood oxygen levels were so low. I'm normally a very active person, but during the asthma attacks, I become quite inactive. I'm sorry, but I can get grumpy, at least my friends and relatives tell me that. And I think I also get depressed on the worst occasions. This affects my family and my friends, of course. I occasionally lack confidence with balance when my ears are full of fluid. Usually it's when my ears are affected on one side, so I feel imbalanced. This is not the inner ear sense of balance, your semicircular canals and things like that. It's more of a feeling of insecurity, particularly when deaf in only one ear, as I said. Then I really mourn enjoying the flavour of food and wine. That's something that I'm reminded of every day when I eat. I used to be a private pilot, and I actually love flying, but haven't flown commercially for years because I really doubt my ability to be able to equalize pressure coming into the descent. So I miss out on holidays and other opportunities that involve traveling by air. Now I find that it seems like I'm always queuing at my local pharmacy for an array of drugs, which included various types of nose drops, nose sprays, oral steroids, anhydronic acid, which is to counter the side effects of the steroids, eardrops, inhalers, and occasionally antibiotics. Then I have a routine twice a day, or try and do it twice a day, when I boil water to create a sterile saline solution, and then I rinse the sinuses using a neti pot. I do that religiously, but I doubt whether it does any good. So, coping with the condition, well, I had resigned to my loss of smell being permanent, but in 2019, I was given oral steroids, prednisone, for the first time, along with a course of antibiotics. This was in response to a cry for help to my GP because the ear problems were becoming unbearable. And I was astounded because as well as clearing up my ears, my asthma completely disappeared along with all of the other CRS symptoms. What was most astounding was that I could then smell and I could taste my food again, which is beyond incredible after so many years of not being able to do it. It proved to me that there's nothing wrong with my olfactory system. It was just being masked in some way. Presumably that's inflammation. I've not given up hope that my CRS might magically disappear as quickly as it started, or that I can even better control some aspects of it. I'm hopeful that a biological treatment becomes available one day, and one that can be afforded, because I think some of the present ones are currently prohibitively expensive. I also heard that there's a promise in a possibility of nasal mucus transplant, which sounds pretty awful, but if it works, fine. And that's where a patient benefits from a nasal microbiomes taken from a healthy individual, such as a relative. I would also say that joining an organisation such as Fifth Sense has helped, because you learn about your condition by reading papers and shared experiences where you have Zoom meetings and what have you. And you might even be able to help others. Otherwise, you think that you're the only one that suffers from your condition. I hope I'm helping to do that in a very small way by giving this talk. I simply refuse to enjoy eating and drinking because, after all, I've still got the ability to detect the 5 basic tastes, even if I have no ability to perceive flavours without a sense of smell. So I try and choose food that delivers up on those basic tastes, together with the contrasting textures and temperatures. I've incidentally learnt that we have a particular taste sensor that is only activated in the combined presence of sweet and salt, such as salted caramel, and that results in a heightened response, which I believe is called hedonistic escalation, and that explains why I particularly enjoy that contrast. I've also just learnt that pineapple contains an enzyme called bromelain, and that can reduce sinus inflammation as well as the thinning of the viscous mucus. And that may even help with the gunk that I generate in my middle ear. So that's on my shopping list every week now. And lastly, my perceived reaction from the medical profession. Well, firstly, I appreciate that my condition is not life-threatening and probably a lower medical priority as a result. But my impression is that CRS and anosmia, loss of smell, is perhaps regarded as a relatively minor complaint. I hope that, having explained what I've experienced, you might feel differently. I imagine that medical professionals must disapprove of self-diagnosis using the internet. However, I did have to ask my ENT consultant at the time, after a year of treatment, whether my condition was termed chronic rhinosinusitis, because I hadn't been told. And on another occasion, I asked the same doctor if my sense of smell might return. and I was told that this was unlikely as the cause was a virus. I left the surgery feeling very disheartened. I've also asked if my condition is incurable, but no one's ever given me the answer. So looking into that, my understanding is that it's probably not curable, but hopefully can be controlled to some extent, and with medical improvements, this might be even more promising. So that's it. Thank you very much for the opportunity to tell my story today.
Thank you so much, Trevor. You've really picked up on, your story just emphasizes the impact that it has on someone's quality of life. And you've picked up on certain things that there are people talking in the thread about things like inflammation, which I'm sure Isma will come on to. The fact that you've managed to still be positive, still not give up on this enjoyment of food and doing what you can to manage the condition. And like you highlighted, being part of fifth sense, if your smell is affected as well, and taste, being part of that so you can get support from other people and talk things through and come up with ideas. Some of the things you've mentioned tonight might be new to some people, and it's always worth a try. So what we'll do is we'll hand over to Isma now, and I'm sure you'll address quite a lot of the things that Trevor's raised, won't you, Isma?
Good evening, everyone. So that was Trevor's story is not too dissimilar to a lot of my patients, and I'd say we sort of categorize patients in terms of mild, moderate, and severe, and he definitely has very severe symptoms which have a significant impact on quality of life. So I'll go through, and obviously if you've got any questions, then where they have very severe CRS due to mental factors. So in terms of the degree of CRS, that can vary from patient to patient, and we'll go through that. So in terms of the etiology, I think Trevor's already alluded to this. It's multifactorial, and we don't really necessarily understand exactly what triggers somebody to go from having a nasal cavity. Part of it, we think, is a dysregulated immune response, and whether that is due to your genetics and how you respond to the environment, whether it's due to a significant triggering factor, which can sometimes be a significant infection, which may be due to a bacteria, a fungus, or virus. That can lead to an autoimmune response. And sometimes when you can have something called impaired mucociliary clearance. So if you've got a lot of very thick mucus, that can affect how the small cilia, which are small hair cells within the cells that move the mucus function, that can affect how things are cleared from the sinus. And if you've got a lot of stagnant mucus, especially if it's infected, you get a change in what we call the microbiome. So we all have bacteria in our sinuses, and there's a healthy balance of that bacteria, similar to how we have bacteria in our gut. Sometimes if some of those bacteria, particularly one of the pathogens which you may have heard of called Staphylococcus aureus, which is found over-regulates or over-inhabitates, it can trigger an immune response within the body. So we know there's inflammation. We don't really understand what triggers one person to clear these sorts of inflammations and another person to end up with persistent inflammation. And I think that's the key to working out a cure for chronic rhinosinusitis. Genetic factors we're aware of. Some people have a better response and how they various pathogens than others, but there are also genetic conditions predispose you to having chronic rhinosinusitis. If you do have genetic factors that impair how your cilia in the sinus were developed, or if you have a structural problem, then that can lead to having chronic problems as well. And as Trevor's already mentioned, in terms of asthma, about between 20 to 60% of patients will have asthma alongside chronic rhinosinusitis. Now, in terms of diagnosis, it's a diagnosis based on a couple of factors. So first of all, the word chronic, if you've had symptoms for more than 12 weeks, then we would class you've had symptoms less than 12 weeks, and that's something that we describe as acute. And then the other factors that we're looking for, and these are a definition from the European position paper. So it's a sort of a consensus statement by lots of clinicians, which also involves patient involvement, is the presence of nasal blockage or obstruction, congestion, and nasal discharge, which may be anterior, which we describe medically as rhinorrhea, and postnasal drip, alongside having facial pain or pressure, plus or minus a reduction in loss of sense of smell. And in children that have CRS, they usually present with a cough as well. That's then confirmed with examination. So when we have a look in the nose with a camera or with a speculum and a headlight, and also if we do a CT scan, that may show inflammation within the sinuses. So once we've got a diagnosis of chronic rhinosinusitis, we then phenotype it. That's a medical term for saying what it looks like. So if you've got polyps in the nasal cavity, that's chronic rhinosinusitis with nasal polyps. And if you haven't got polyps, but just inflammation and mucus, then you've got CRS without nasal polyps. And in terms of how you treat those, there's not a significant difference, but we do know that the inflammatory pathway is slightly different in the two. So this is a really, really busy slide. And the purpose of this is just to show you how many different factors are inflammation. And when we're trying to target treatment, we're trying to target it sort of at different aspects of the pathway. So what we think happens is something happens, an allergen comes, some sort of inflammatory process. You've got various cells that are designed by the body to fight those pathogens that are causing inflammation, and there's various factors that are released to try and help with that. Now, sometimes there can be an overexpression of some of those factors, which can then lead to chronic inflammation. But there's, if you look at, Trevor described having some oral steroids, so that's corticosteroids. So they're very effective, but I'll go into a bit of detail later on why I can't have you all on corticosteroids. And then there's a number of factors released by the T helper cells, which are the main sort of factory, let's say, that produces a lot of these inflammatory factors, and they tend to sort of over release a lot of inflammatory factors, and so they then have an effect on these cells here, which are eosinophils, and also B cells. So we will look at some of the medications that target different bits of the pathway, and that's what the research and the newer medications, the biologics that we call them, are designed to do, to try and target different aspects of this pathway. So in terms of treatment, initial treatment is with saline rinses. And why is that important? It seems like a very trivial thing to do. Like Trevor said, I wash my nose up. I'm not sure that it does any good. What we think happens is that the mucus that you've got sitting in your sinuses has these bacteria that are triggering inflammation and also possibly worsening the inflammation. So the idea is, if you try and wash that inflamed mucus away, that should reduce the amount of inflammation within the sinuses. So that's one of the reasons for using saline rinses. That can either be a saline spray or a douche. Some people find the douche quite uncomfortable, so they may prefer to use a saline spray. It doesn't matter which brand you use, as long as you're using it regularly. Once that's been done, that also means that you now have the mucus clear, so that any medication that you use can now actually reach the sinus lining. Now, if you imagine, if you've got a lot of thick mucus there and you're using your nasal spray or your nasal drops, well, it's not really going to reach the sinus lining if you've got a lot of mucus sitting in between the spray and the lining of the sinus wall. So we recommend washing the sinus out so that you've got an exposed area of mucosa, which is the lining of the sinus, and then you put your spray or your drops in. Usually I recommend to patients to because if you've used a nasal, you might find that sometimes you turn your hand and a little bit more water comes through after you've done the rinse, so you don't just apply it. INCS is just a fancy acronym for saying intranasal corticosteroid, which is spray or nasal drops. Now, the majority will be given a nasal spray. That's safe to use. It's not going to cause you any systemic side effects. So the way I explain it to my patients is, you've got a similar thing to asthma, but it's inside the nose, and you need to use an inhaler and the inhaler is your nasal spray. So we would always keep people a baseline nasal spray. When there's an exacerbation, so when you get these flare-ups, which Trevor described really nicely, then upscale your treatment for nasal drops, form of oral steroids. The other thing to be aware of is compliance. So I always say to my patients, the first few weeks that you use a nasal spray, you're going to notice no difference whatsoever. You need to reach a threshold where the spray is present and starting to cause a change in the sinus lining for it to be effective. So that's usually about 4 to 6 weeks into using the spray. And in terms you should sort of pop your head down slightly, nozzle into towards the ear on the same side, and then copy that maneuver on the other side. So you want to angle it towards the ear rather than the midline, because the midline is just going to hit the septum, and that's not going to be very effective. We tend to avoid antibiotics unless there's evidence of pus there, and that's with good reason, because we don't want to cause any resistance. And we would always look for treatable causes. So if there was some sort of other pathology, so if there was, it looked like there was just a polyp on one side, we'd be worried about that. If somebody had significant bleeding, those are things that we would worry about. And that would, if you were seen in a general practice setting, trigger referral to ENT. Now, most GPs will give you that treatment and wait for 6 to 12 weeks. And if it doesn't settle down, then refer you to ENT. And whilst you're waiting ENT review, they may give you a course of steroid drops for 6 weeks, or oral steroids. So,
Isma, if I could just interrupt briefly, there's a little problem with sound. I keep thinking it's going to settle down, but occasionally you're cutting out. So
okay.
if I could just ask you to slow down a little, it might mean that if it does cut out, people can still pick up on what you're saying.
Absolutely.
Thank you.
Sorry about that.
That's all right. Thank you.
So in terms of steroid drops, we don't recommend using them all of the time because they are more potent and you do end up with systemic side effects of using steroids. The main one being diabetes or osteoporosis. So we tend not to give you steroid drops all of the time. You can have up to 3 courses of steroid drops. So that's 6-week courses a year. The same for systemic oral steroids. So oral steroids, again, can have a significant impact on your general health. And we know that over your lifetime, and at the moment, this is a chronic disease. So over your lifetime, if you use oral steroids repetitively, that can have a significant impact on your general health and well-being. So you can have up to 3 courses of oral steroids a year, but no more than that. And if you're requiring more than that, then we need to look at other treatment options. The other thing to be aware of is that you can concomitantly, so at the same time, also have allergic rhinitis. So you may have allergies and you can use antihistamines to treat that. And that can sometimes help with the amount of fluid that's being produced in the nose and to help dry that up. And if you've also got asthma, then we need to optimize your asthma care, because we describe sort of the airway as a shared airway. So you've got your upper airway, which is your sinuses, and your lower airway, which is your lungs. Make sure that both are treated as well as possible to ensure that your breathing is optimum. If that doesn't work, then we do offer you surgery. And this is a picture of somebody with significant nasal polyps. And surgery is not a cure, but the idea behind surgery is we take the polyps away, we open up the sinuses, we give them a good washout, and then that should help reach the sinus wall. So again, the objective is to medication to the right. Do you have in the sinuses, mainly the frontal sinus, because that's an area which has a very narrow opening that can sit there and release steroids, but the evidence in terms of how effective they are is not really strong yet. So we do have other things that we can apply to the sinus, but we're not sure whether that works 100%. Now, some people may also give you some steroids to apply to your nasal rinse, and I do that with some of my patients who I describe as having severe CRS, and that's usually a nebulizer. It's a steroid again, but you apply it to the nasal rinse. So if you're using, say, Neomed, we ask you to use that in the nasal rinse instead of using the steroid spray, and that's a little bit more effective because as you wash out, the steroid can reach the lining a little bit more effectively. So at the moment on the NHS, these are the treatment options that we have. The other things that we may offer you are, number one, antibiotics. Now, there is a class of antibiotics that we tend to give you for about 3 weeks, which has an anti-inflammatory effect on the sinus lining. So you may get antibiotics for 3 weeks to help with that. Depending on whether you have chronic rhinosinusitis with polyps or without polyps, differentiates which antibiotic we use, because there's a certain class that works better with people with polyps, and there's a certain class that works better with people without polyps. The other medication, which is the biologics, is called a monoclonal antibody. So if you recall that really busy slide with the pathway, the monoclonal antibodies are designed to hit different aspects of the pathway. So this is just a summary, and it's a busy slide, and it's got lots of difficult medical words on, and I can't say most of them. I think they'd probably have a competition to see who can come up with the most difficult monoclonal antibody name. We've got the IgE, which is your inflammatory marker that sort of starts off the cascade of inflammation. And this is a common drug which a lot of people with asthma may have been offered if they've got really severe asthma. But we know that this doesn't work in all patients with CRS. Now, different patients have different levels of these inflammatory markers. And the idea behind using different medications is eventually, I would think you would test and we'd be able to markers are predominant in your condition, in your CRS, and then we would target treatment. So that is where I think we'd end up in the future, and that's called endotyping. So phenotyping is how it looks on examination. Endotyping is what your inflammatory markers are doing. And so eventually we will probably do a blood test and say, well, according to that, you would most likely be treated with this medication. These medications are extremely expensive and they're not readily available, and they're not available on the NHS at the moment. Pre-COVID, we did think that we would have dupilumab available for our chronic rhinosinusitis patients, because we found with this research that has been done so far, dupilumab seems to be the one that has had the most success in helping nasal symptoms and sense of smell. Sense of smell being a really important factor for a lot of CRS patients. But we don't have that available yet. The main implication in that is cost. And sadly, we're the only European country where clinicians can't just prescribe monoclonal antibiotics on the health service. You can get it privately, but it's extremely expensive. And I wouldn't recommend this for all patients. So if you're a patient who uses a nasal rinse and a nasal spray, and that controls your symptoms adequately, you wouldn't need this. We don't know how long the effects of this are sustained either. So it's an alternate, but it's not a cure either. So in terms of research, in my practice, to try and get my patients some of these medications, we do run some research trials. The macro trial was a trial that's just come to conclusion, which was a national trial run in the UK. And that was actually comparing everyone used a baseline steroid spray, and then they got tablets. Now, some people got tablets which were an active antibiotic, and some people got tablets which are dummy tablets. Just come to a close this trial, and we're going to see whether that antibiotic has an effect on people with CRS with polyps. In my unit itself, we're just coming to a close of the Everest study. Now, Everest study was a randomized control trial, which means I don't know what you're getting, you don't know what you're getting. The computer decides, and I'm blinded to what you're going to get. With Everest was comparing two different monoclonal antibodies. So PRS with polyps, severe asthma, and there's a strict sort of entrance criteria for all of these trials. So the inclusion criteria is quite stringent. And if you pass the inclusion criteria, then you get the medication every 2 weeks. So that trial's just coming to a close now. We don't know what the results are. I don't know what my patients had, but eventually we'll be given that feedback. There's another trial that will be starting at the Newcastle hospitals in September, which is, again, the Everest trial was an international trial, and Eli Lilly is also an international trial looking at a different monoclonal antibody. But the two groups of patients, again, it will be blinded, so I won't know what you're getting. The patient doesn't know what they're getting. Will be placebo, so you'll be getting an injection that has nothing in it, or an active monoclonal antibody. So it's comparing the two to see whether there's any impact and what impact there is. And there's a third trial that we're due to start, but we're just about to find to be a site for that, so I haven't mentioned that. So the future in terms of treatment for patients with really severe disease is most likely biologic. You know, then next year, biologics available for certain patients on the NHS. But the main factor in that is sort of cost and economics. Okay, well, I'll just stop screen sharing.
Thank you, Isma. That was great. There's been a few questions in the chat. I think people were mostly just really listening to what you were saying, so there may be some more questions pop up later. So if I just pick up on a few first, I mean, the first one that really springs to mind is you're talking about the monoclonal antibodies. There's a question here: if they do become available, would our GPs be able to offer them, or would it only be through ENT surgeons?
It should be through a specialist service. I think it's unlikely that GPs would be able to prescribe them initially down the line, but because they're such a costly drug, the clinical approving authority always has criteria, so they most likely would set NICE guidelines of which patients would qualify, and when they decide on that, they look at the health economics and how much of a cost benefit ratio there will be for the number of people treated. So they will have guidelines for us in terms of who we can prescribe it to.
Yeah, and I know that Duncan was involved in some discussions about that, about trying to represent patients' views. So if anybody's interested in sharing their view as a patient, if they email me at information@fifthsense.co.uk, I will be able to send you the link to that survey. The discussion that Duncan was having is closed now, but your feedback is always useful for whenever Duncan's having dialogues with organisations about this kind of thing. So if you want to fill in that survey, I can send you a link. It's also been advertised in our newsletters, so you might be able to pick it up from there too. Okay, so in terms of other questions then, so please could you briefly explain the difference between the INCS, the corticosteroid nasal spray, and the OTC, also a steroid spray, or was it something else? I think that might have been because the sound was cutting out a little on some of the things that you said.
Yeah, I think it says my internet connection is unstable. I can only apologize for that.
Thank you.
So over the counter. Now, you can get steroid nasal sprays over the counter, but they're not as potent as the ones that you can get from your GP in terms of the dosage. The main difference is the dosage, and some of the medications are not available over the counter. So most people will sort of maybe try to get something like Beckinase over the counter to start off with, but then we usually upscale. So in terms of, as a rhinologist, I find that Beckinase is not as effective, and in terms of bioavailability, it does have more systemic side effects. So I tend to start people off on mometasone or fluticasone because I find that they're quite effective. Then we have other nasal sprays that have an antihistamine added into them. So there's 2 on the market. So if you've got an element of allergies, if you produce a lot of mucus, those are a little bit more effective for those patients, especially the ones with postnasal drip.
You. And in terms of the trials, the trials that you're going to be doing that aren't closed, how can patients get involved? Do they have to be one of your patients, or?
So they can email us.
Seem to have lost Isma there. Let me just give her a moment to reply. Hello, Isma.
So
We didn't hear your answer at all to that question about how people can get
Okay.
involved. Your internet did cut out there.
Okay. So there are 4 sites going to be selected for one of the trials. I'm not sure what the other sites are, but different hospitals. Usually it's teaching hospitals where trials are run. So your GP can refer you to your local ENT surgeon, and if there's a trial in the region, they can refer you to that. You know, with Choose and Book, you can ask to be referred specifically to our unit, but obviously that involves travel, and these trials involve having an injection every 2 weeks if you qualify, which would be a lot of travel.
Okay,
But
and
generally
of course, yeah. And
through
if there
clinic.
are any research projects, we advertise that through our newsletter
Yeah,
to members.
absolutely.
So if there are ways
Yeah.
for you to get involved, we'll let you know. Okay. Let me see if there's any more questions. A lot of people resonating with what Trevor was saying, having similar experiences. Okay, question here. Could you say something about aspirin desensitization? Do ENTs still work with immunologists to offer this? I was treated very effectively about 8 years ago.
So I don't work with an immunologist. I have a close contact with an immunologist, but generally the immunologist, I offer immunotherapy for my patients that have certain allergies. So on the NHS, you can have immunotherapy for, say, grass allergy, tree allergy, and house dust mite. So I offer that to my patients. So I don't necessarily work with an immunologist, but if they're patients and I think there's a significant allergy component to their problem, then I will refer them to my immunology colleagues.
Thank you. Another question, Isma. Do you use theophylline?
I don't use theophylline. Yeah, the evidence for that is limited, so I don't tend to use it. No.
The evidence is limited. Yeah. Okay. Okay. And another one, apologies, I've pronounced everything wrong here. Why am I advised not to use fluticasone for more than 3 months? Isma might have cut out again.
Fluticasone.
Fluticasone.
Yes. So fluticasone nasal spray you can use all the time, every day. That's absolutely fine. You're not going to get any side effects from that. Fluticasone nasal drops you can use 6 weeks at a time, 3 times a year. You're advised not to use it regularly because you will absorb the steroid and that will cause systemic side effects.
Thank you. Someone says they heard that Becanase is not particularly effective, but they didn't catch the name of the true treatments that are used in preference. And could you say the names again, please?
So mometasone and fluticasone.
If there are anything that people can't hear, obviously I'll be in touch with Isma after the call, and we can send you an email confirming some of these names if that's easier. Okay. Have you found any use for balloon dilation? Do you want to repeat it again, Isma?
Yeah, mometasone and fluticasone. I've written it in the chat.
Thank you. Have you found any use for balloon dilation?
I did try balloon dilatation. I think it has a limited use in certain settings. I don't think it's got a particular use in chronic CRS.
Thank you. Is there any known connection between corticosteroidal nasal spray and anosmia? I've been using nasal sprays for 20 years. I recently tried to stop taking the spray. My CRS symptoms have worsened a bit, but my sense of smell has improved.
There isn't, it should improve your sense of smell, because we think that people have anosmia because the polyps are causing a physical obstruction. So the air is not flowing around the top of the nose, which is where your sense of smell nerves come through. So it should make it better rather than worse. So I can't really explain that sort of medically.
Question to ask your own your own consultant, really, isn't it?
Yeah, maybe something to look into.
Yeah, okay. Is CRS associated with people like me who have not got frontal sinuses?
No, and not having frontal sinuses is an anatomical variant, so there's no direct correlation with that.
Thank you. How are we doing for time? So we've got 4 minutes left. I can't see any other questions in the chat at the moment, unless I'm missing something, in which case please do feel free to drop it in again.
Rachel has written, I have aspirin allergy. So it's not uncommon for patients with severe CRS to have a combination of asthma, aspirin, allergy, or allergy to non-steroidal anti-inflammatories, and have polyps. And that's what we, as medical terms, call Samter's triad, because Samter described it. There is a treatment for these patients, which I am trying to get, but it's a bit tricky. It's called aspirin desensitization. And the idea is you bring the patient in and you give them small increments of aspirin and you keep them on the ward, because it can initially trigger a respiratory problem and a nasal problem. And that's why you want a close observation. But the idea is by giving the thing that's causing inflammation, it causes a reaction and eventually your CRS should die down. But we don't have that readily available in all NHS trusts.
Okay, thank you. And then a question here from Robin. How easy is it to get to see a specialist? So I wanted to ask you anyway to just talk to us about the patient pathway. So you talked about at the beginning about people managing things for a period of time first, then talking to the GP, and then the next step of the GP. How long would a patient work with a GP before they're referred on, Isma, to a consultant?
So if they've not had any response to treatment between 6 to 12 weeks of regular treatment, then the GP would refer on to ENT. In the meantime, they may get, most hospitals have a section called advice and guidance. You can directly contact ENT, and in the meantime, they can give some advice on how we can give other treatments whilst they're waiting for the appointment. So that's when you might get a course of oral steroids or a course of antibiotics for a few weeks. And then you would be seeing an ENT. How quickly you're seen depends on the local waiting list. I know in our trust at the moment, you could be waiting about 6 to get an appointment for something what is described as routine.
You cut out there. Did you say 6 weeks or 6 months?
6 months. 6 months.
Okay,
yeah.
I thought so. Okay. What do we know about the impact of food intolerances on this condition?
So we do think that salicylates in certain patients do trigger, and that's why some people might follow a low salicylate diet, but that's not the hard and fast rule for a lot of patients. Again, like I described, different people have different bits of the inflammatory pathway that are triggering this inflammation, and when we are able to target that better, then we'll be able to possibly even give advice on what food may trigger a flare-up.
Thank you. Yeah, Tim's saying it was a year before he got to see his consultant in Edinburgh, after having been referred. Okay. If CRS and anosmia is possibly associated with histamine intolerance, what over-the-counter antihistamine would you suggest?
I mean, there's a number of them available. Cetirizine is a sort of an easy-to-use one, or loratadine. The strongest one that you can get over the counter is fexofenadine. That's something that previously only healthcare professionals could prescribe, but you can get that over the counter now. So fexofenadine is the strongest one.
Thank you. So I can't see any more questions, so it's probably time to start bringing it to a close anyway. yeah, someone's asking us to write these names down. So I'll ask you afterwards, Isma, to provide us with a little summary. And if anyone wants that, if they just email in, I'll send that to them. Oh, you've done it there. I won't need to. Thank you. And everyone, you can save the chat at the end of the event. So if you go to the 3 dots on the bottom, you should be able to save the chat, so you'll be able to see these after the call as well. Okay, so I think we'll end the Q&A there. I'd like to just thank Isma and Trevor for your presentations and explaining things so clearly. I apologise on Isma's behalf that there was that connection issue. It's unfortunate when these things happen, but we will try and clarify anything that anybody missed. Helen has dropped a SurveyMonkey link in the chat there. I don't know if you want to drop it in again, Helen, just to be clear, but because there's lots of other things in there. There are links to clinics, so various links that Helen was posting in, particularly as Trevor was talking about the self-help measures and that kind of thing that people might find useful. So a couple of notices then, really. So for any medics who've joined us, just to say, you know, you're very welcome to join us as a supporter for Fifth Sense, and then you will hear about some of the things that might be more relevant to you, including at the moment, we just want to make people aware, medics aware, that there is a 2-day symposium on smell and taste disorders at the University of East Anglia, and that's from the 30th to the 31st of May. If any medics are interested in attending that, if you could please email my colleague Sarah Pierce, so at fifthsense.org.uk, I'll drop that in the link, and she should be able to send you some further information. Send chat to meeting room. Sorry, I'm not good at this now. There. So that's Sarah's email address. And for any patients who've lost their sense of smell due to CRS, again, you're welcome to join us if you're not already a Fifth Sense member. So we'll pop the link in the chat for you to join Fifth Sense as well. It's free to join, and we keep you up to date with what's going on, including, as we mentioned earlier, our Let's Talk Smell and Taste events. So if you have a loss of smell due to CRS, then the appropriate event for you to join would be the Acquired Anosmia event, which is on the 15th of May. You can reserve the place using this link here, which I'll pop into the chat, but we would strongly ask you to join Fifth Sense as a member, and then you won't miss out on these things. It's different just getting the event cube link, you're missing other things. So we'll give time for people to obviously fill the survey out. The other thing to draw everyone's attention to is if you're having problems with your smell loss or distortion, then obviously staying safe might well be an issue for you. You may not be able to smell gas leaks and that kind of thing. So Helen's popped a link in the chat there to our Staying Safe page on the website. So do have a look at that. That's really important. And Brian, you're asking how to save the chat. So if you go to the 3 dots at the bottom of your screen, you should get a little menu there that says chat, and then you should be able to save the chat. Helen might jump in here. She's much better explaining that than I am. No dots. Okay, let's have a look. So at the very bottom of the chat box, then, Brian, if you click down on the right, the white bit, so you've got some different symbols, including a smiley face emoji, along the bottom of your screen on the white part of the chat, and you should be able to save the chat there. Anybody who's having problems with that, just please email me at information@fifthsense.org.uk, and I will send you a copy of the chat. Okay.
Mags, sorry, Mags,
Yeah.
just say, I don't think we can, if we're not co-hosts, we can't get the dots. So I don't think
okay. In that
the
case,
participants will be able to do that. So I think it would need to be sent out.
Thank you. That's very helpful. So anybody who wants that, please email me in and I'll send that out. I can't send it to everybody because we had, 150 people sign up for this event and not everybody's attended. So I only want to send it to people who've attended to save any confusion. Okay. So what we'd like to do now is we'll end the event, and I'd like to say a really big thank you to Trevor and to Isma for contributing to this event. That's what makes these events work. This is the first one we've run like this, and I think it's, from my point of view, it's gone exactly how I wanted it to go. So I'm very grateful for that. Thank you. So what we'll do is we'll end the session there. So we'll pop people back in the waiting room. That'll give you a chance to complete the survey if you haven't, or to pick up anything from the chat that you just want to harvest for yourself. And we hope to see you at a future event. Thank you very much. Bye now. Bye.